Looks like we've got a good crowd. If I can kick it off now, what do you think?
Sure, go for it.
All right. Well, welcome everybody for our very first Chat with Chat webinar. The name will soon make sense to you, I believe. And we're so excited to have all of you here live, and for everybody who's watching this on our YouTube channel. Hopefully you can join us live for the next one, but thank you all for being here. I'm going to kick it off first to Sarah Loud, who is our CEO of the Accelerated Cure Project, and she's going to give you all a little bit of background about what we do.
Thank you so much, Stephanie. So hi, everyone. I'm Sarah. As Stephanie said, I'm the CEO of Accelerated Cure Project. And Accelerated Cure Project is the nonprofit that is behind iConquerMS. I think many of you know of iConquerMS, but we'll spend a little bit of time talking about it. Before we get started, I just want to say welcome. Stephanie pointed out this is our first Chat with Chat, and so you're an early adopter, and thank you so much for being here. Please mute yourself during the meeting, and we'd love for this to be interactive. So if you'd like to submit a question or a comment at any point, please submit it to the chat. And you'll find it most likely at the bottom of your screen, and that will give you an opportunity to share your thoughts. And one of us or more of us will be monitoring the chat, and we can ask you to ask your question or provide your comment live if you're comfortable doing that. And at any point, if you'd like to ask us a question, and this isn't from the live perspective, you can always connect with us at info@iConquerMS.org. Okay, so let me tell you a little bit about us. So our mission is to improve the health, healthcare, and quality of life for people living with MS. And we do that in a highly collaborative way by connecting those affected by MS, including caregivers, clinicians, and researchers, and we all come together to work to accelerate innovation, research, and the application of new knowledge. A little bit about Accelerated Cure Project. So we are patient founded. We are 20 years old. I can't believe it. And we've been working for the last 20 years in collaboration with stakeholders to accelerate research. Our initial focus was on determining the cause and finding a cure. But our work has evolved as the patient priorities and patient needs have evolved. And now we're highly focused on enabling people-powered research with the prioritization of the needs of people affected by MS. We do that in a number of ways. We have three main programs. We have the ACP repository, which is a centralized collection of biosamples and data from people living with MS. We also have iConquerMS, which is our people-powered research network. I know that some of you on this call are members, and I hope by the end of this call, all of you will want to be members. And then we also have the MS Minority Research Engagement Partnership Network, which is a network, a multi-stakeholder network that focuses on understanding and addressing the barriers to participation for underrepresented populations. And all of these things come together along with people living with MS and other stakeholders to be resources for driving research and improving care and enabling cures. So a little bit about iConquerMS. It's the MS People Powered Research Network. These are real participants. You might recognize some of them actually, because some are social media influencers and others, but it's a virtual network. We established it in 2014, excuse me, and it's been growing ever since. We have more than 7,500 participants now who basically consent and participate in research from the comfort of their own homes. It's truly people powered. It's a resource to gather insights and expertise and data and biospecimens from people who are affected by MS. So as a member of iConquerMS, you can log in from your home, you can complete surveys, you can offer insights as to what topics you think need to be studied. There's all sorts of ways to participate in iConquerMS and participate in research. It's patient governed. We have a really robust governance structure, including a governing board, an engagement committee, and a research committee, so that everything that we do is approved and sanctioned and designed and developed by people living with MS and other stakeholders. We also have representatives from most of the other MS advocacy organizations. So this is truly a collaborative resource where MS research and MS advocacy organizations come together to make sure that research is done on topics that matter most to people living with MS. And it's inclusive. It all comers, anyone affected by MS, including care partners, are welcome to join. Here's some of the ways that we engage with our community at iConquerMS. If you're a member already, you might recognize this view. This is the dashboard where you would find your open surveys, in-progress surveys, and completed surveys. So you have an opportunity to submit information about your experiences of living with MS or living with someone who lives with MS. We also work with researchers to do lots of interesting surveys and other types of engagements where we bring together researchers and people living with the disease and care partners to share their insights, either through ad hoc surveys, like quick surveys on different topics, or to participate in focus groups and the like, so that you can contribute your experiences and your ideas about study design and study execution. And then we've recently launched something called Our Questions Have Power, which enables our community members to submit topics and questions that they think should be studied, and then to vote on and prioritize the questions that other people have submitted. You might be wondering how we're accelerating COVID-19 research and how you can be involved in that. We actually have a number of different ways right now. As an iConquerMS member, you can help conquer COVID-19 in 3 important ways. You can participate in the COVID-19 vaccination and MS study. It's called CoverMS. And what we're doing is we're gathering information as people are getting vaccinated on their experiences with the vaccination. You can participate in the Our Questions Have Power program, which I just mentioned. You can propose a question about COVID-19 and MS, or you can comment on and prioritize and vote on questions that have already been submitted. And then we also have an iConquerMS survey just about experiences during the coronavirus pandemic. If you're not yet a member, I hope that you'll consider joining now or close to now. So just a moment again on the participant-driven research, which is the Our Questions Have Power program. So here's an example of a question that's been submitted by a member of the community. Should people with MS on B-cell depleting therapies be tested for antibodies after being fully vaccinated? So what happens is you have an opportunity to vote on this question. Does it feel as though this question should be a high priority? Would the results of this research be helpful to you, and would you be interested in participating in research? You can also add your comments here or see the comments of other people. And Our Questions Have Power is a program that is going to develop a prioritized research agenda working with the community. So we can take your topics, we can prioritize them, and then work with you and researchers and funders to develop research projects and to get funding so that we can study the topics that matter most to you. And we actually have a real life example of this. The vaccination study that I mentioned, CoverMS, was submitted by a member or members of our community as a high priority topic of interest. And we were able to work with the community and with funders and researchers to bring that into a fully funded study that's ongoing right now. Want to just mention one thing about our approach to diversity, equity, and inclusion. Quite a few years ago, actually, we recognized this as an issue within MS research and care. And so we developed the MS Minority Research Engagement Partnership Network. And what this network does, it's a multi-stakeholder network. Lots of people come together to discuss the barriers and how to overcome them to participation in research. We have a number of programs that are part of this network, and we'd be happy to talk to you about your interest in better understanding what we're doing and ways to get involved. So here's just a few ways that as a member of iConquerMS, you can contribute to driving, shaping, and accelerating research and innovation. You can be members of focus groups or patient advisory boards. You can contribute to surveys. You can participate in things like developing endpoints or contribute to our efforts to increase representation. And you can also participate in the participant-driven research, Our Questions Have Power. If you're not yet a member, please consider joining at iConquerMS.org. And if you are a member, thank you so much. And we're glad to have all of you here today. So thank you. And I'm going to turn this back over to Stephanie.
Thank you so much, Sarah, for sharing that overview. And please, if anybody on has any questions about Accelerated Cure Project or iConquer, put them in the chat and we can certainly get to them towards the end of the call. Now I want to transition a little bit into our chat with chat, and just to give you all a little bit of background, our featured researcher today is Chat. And in webinars from here on out, this is my co-host, by the way, in webinars from here on out, Chat will be interviewing the researchers, hence the name Chat with Chat. So I will let him introduce himself and talk about his research. So Chat, please take it away and tell us a little bit about your work. Come off mute though, Chat.
Obviously that I'm so excited, right? All right. So thank you so much, Stephanie, and for the introduction. And also, I would really like to thank the iConquerMS to, give me opportunity to share my research that I have done with the community a couple of years ago, and just like to let everyone know that how excited I am. Just a matter of the title of this webinar, Chat with Chat, I actually it kind of felt at the beginning, I felt kind of strange, but after all, I felt like it's not a bad idea to have that title. I'm kind of getting used to that one, and happy that you all here as well. So what I kind of like to do is kind of like to set up some ground rule, which actually my ground rule is no rule. So what I like to have is basically, I feel like listen to research is many times, as even though it's my own career, it just kind of can be kind of boring. So I like to kind of make this webinar is more conversational, or more interactive. But and as Stephanie said, that if you have questions or anything, please use that chat function and type in your comment or something that is unclear to you at certain point. Just make sure that you let Stephanie and Sarah and also Hori know. They're gonna monitor that chat window, so then I can definitely respond as soon as I can. So let's begin. So there's a little bit of the background, and I already told my my full name is actually Surachat, but I go by Chat. Okay, so a little bit of background of my project. In fact, this has been maybe in 2015 that, let me advance my slide. So this one should come first. So in 2015, I was kind of sitting with one of my friends when I was in Wisconsin, and he kind of mentioned that his sister, her sister, actually developed, according to her, she called as a weird symptom at that time, because all kind of things, and then we have she had problem with her speech, and she could not really walk properly, fatigue or anything like that. And at that time, and then, there's a couple more phone calls and conversation after that. But finally, she met with the doctor, and it turned out that, quite likely she gonna have MS at that time. Okay, so 2015. Can you imagine a person from Thailand and moved to the state in 2014? Even though I'm a pharmacist by training, but I like to be honest with you, by 2015, I had no idea what multiple sclerosis is. Okay, so after that conversation, I thought that, well, I'm gonna take a look at the multiple sclerosis. So then I learned. And what I learned is basically multiple sclerosis is, there's current treatment is cannot cure the disease. That is one thing. And then another thing, when I look at the treatment itself, that the treatment prices actually is skyrocket. It's way up high. Guess what? My research background, I define it as a pharmaceutical economics and policy. My job is to make, my goal is to make patients at any disease to be able to access their medications and healthcare. So when I see MS, multiple sclerosis, when I learned about MS, and then I found out that the prices of the DMT is really super high, I jump right on, and then start searching and look for the opportunity to do this research right away. It was a big coincidence. The National Multiple Sclerosis Society at that time, they opened up the new, what they call new opportunity for doing this type of the research. And although, sadly enough, they no longer have that in last couple of years. But at that time, they opened up this opportunity. So without hesitation, so I applied. This is actually, the research question is actually come from them. So they are looking for a researcher or as researcher to propose because they really like to know how patients value the the treatment, the MS treatment. So that is why what I propose. And at that time, I don't know, iConquerMS community or anything at all. So, I search more and more. And then after all, I happened to, work with, found iConquerMS and, met with Hori, Robert, and so on. Since then, I became, I think that we became more like a family member now, I guess, for the iConquerMS. So that is a little bit of the background that I have. And I probably talked too much about the background already. So I got my research team at that time. So I was at the South Dakota State University, as you can tell, but I also collaborate with neurologists, two neurologists at that time in Wisconsin and also at the University of South Dakota. And I have somewhat my mentor, Dr. Blixner from University of Utah. In fact, Dr. Blixner is the one who mentioned that I should contact iConquerMS. So this is my outline and nothing really important. I'm going to talk a little bit of the background, which I already did. And then, I'm going to move forward to jump right on to my research. Okay. And I kind of like to talk about the significance of even though we all know, we all feel it, we all experience or experiencing the disease modifying therapies, I'm sure. So, but this is a relatively kind of old data, but if you look at the disease modifying therapy, hold on a second, somehow it's, okay, that's better. So the disease for the annual sale from the IMS Health, which is a consulting firm, in 2008, it just cost the country for like it's like $4 billion. Okay, and 4 years later, it jumped from 4 billion to 9 billion within 4 years. That is what's going on. That is the annual sale. Okay, which is not, there are several kind of costs and prices and, there are several type of the economic burden that people like to present. So then if you look back, there's a report that the average, and again, this data is quite old. So now today it probably, increase or higher than this number. So the average annual DMT cost per person in 2004 is about 16,000. At that time, you gotta remember that DMT at that time is still only a few, maybe less than 1 dozen. But right now in 2006, not right now, in 2006, though, it jumped to 22,000. So the price has been increasing. And this is another kind of give you a snapshot of the DMT and not all, because right now we have over 15 or maybe almost 20 DMTs available for MS. So, but since 1993, the first DMT, you can see the price of, like, for example, the interferon or the beta seron. This is the annual cost. So it costs like 11,000, and then 6 years later it jumped to 86,000. Okay, and that bothersome for everyone, I'm pretty sure, because it is still the same medication. How come a few years later the price jumped up to almost like 90,000? So, and of course that to me as well. A lot of people really think that when I propose this type of the research, I got the question, and it is very critical question, because I present when I present more like a research idea at the society chapter when I was in the Midwest, the upper Midwest. Somebody asked me, who cares that how patient would value the DMT? Because we all live with certain type of the insurance or have some kind of health coverage. Well, guess what? Even though with I respond right away when somebody kind of mentioned that. You got to remember that you may think that some people may think that, hey, I have a really good health insurance coverage, but guess what? We all pay for we all pay the premiums. So if the cost of the healthcare or the medical costs kind of keep going up high, eventually it will come back to us, the one who pay who pay the premium, if you may. So that is the real problem. So, and it turned out that even at that time, even Medicare patient with Part D enrollment still really pay a really big amount of money per year, like 6,000 for this medication. I think that is a lot. Okay, so basically it's about like what, 500 a month, which actually you can spend on something else. So there's of course, when the cost is high, quite likely it's going to have an impact in terms of the access.
Yeah.
In terms of the access to these high DMT prices, okay, and that is the real problem. So as I said, the society raised a question that, so how do patients value DMTs? Because when you talk about the price and the cost, basically the conversation quite likely is between the payer, right, and the providers. But nobody at that time really ever even asked a patient who actually have all the impacts on them, more or less. So that's why the society kind of raised that question. So the objective of this project or this study is really simple. So we basically like to determine the willingness to pay or the patient willingness to pay for the DMT, and use that willingness to pay to reflect how patients value the DMT for multiple sclerosis. Okay, so that is the main objective. So, and the method that I use, in fact, it has been the state of the art in terms of the economic tool to determine the willingness to pay or based on the patient preference. So, which we call as a discrete choice experiment. And I'm more than happy to talk about discrete choice experiment in detail. But I don't think that I don't think we would have enough time to do that. So But I'm gonna kind of give you some ideas about the overview of what I have been doing for this study. So we have the first step for the study. We need to identify important what we call as a technical term as the attribute. But basically, this is the important characteristic or the characteristics of DMT that are important to the patients. Okay, so we did 3 different steps. So we did the literature review and see, what are important. And we did the in-depth interviews. So we basically talked one by one between me. I did it myself. I talked with 5 neurologists. And I also did a group discussion with 5 patients. And the next slide going to be very interesting result for this step. Okay, so this is what I found. After I, spend an hour talking with each neurologist. So 1 hour with 1 neurologist, and then I spent like 2 hours talking with only 5 patients. You can see that I got a list of the what I call as the DMT attribute, or in fact the DMT characteristics. Okay, what really is striking me, which is not a surprise, that the neurologist, from the neurologist standpoint, the cost of DMT is at the bottom of the list. Okay. On the other hand, when I talk with the patients, the cost of DMT actually is on top of the list. So there's something going on between, because they're not together, right? So when I talk with the neurologist, even though this happened in 2016 or 2017, about that, I still remember very clearly. Almost all neurologists would say that all of my patients never have problem in terms of the cost of the the cost of DMT will never stop or prohibit my patient access to the DMT. Okay. On the other hand, when I talk with the patients group, I actually brought that up. I did a patient group after I talked with the neurologist. Okay. And I said that, well, according to the neurologist, they said that you guys should not have any problem about the cost. They said, well, Shad, that can be true and not true. Okay, because I remember very clearly, one of them said, yeah, we can get some kind of assistant program, but I have to wait for like 1 or 2 years in order to get access to the DMT. And time is really critical for a patient who get diagnosed with the MS. And that particular example, actually, it's not only the clinic itself or the assistant program. I think she was under consideration with the social security program or assistant, that kind of stuff. So it took her almost like over a year in order to get access to. So for her, she considered cost is really the most important factor in terms of the getting access to DMT. So for the
Kat, can I interrupt for just a second? We
Yep.
did have a question in the chat.
Yep.
And this is from Joy, who says that Okravis and Kesimpta have similar mechanisms, but one is infused, I guess, at a clinic, and one is given at home. And Medicare Part B covers infusion, but not at home administration. So is that something you could comment on? And Joy, if you have any other, other parts of your question you'd like to ask, you can come off mute and ask that.
I actually can give a maybe just only little kind of minimal comment on that, but I just that's good to know. In fact, I don't know. First of all, I don't know about that, but I know that there's whenever either the payer make that type of a decision, okay, so when they make the decision, when the payer make decision, there are a couple of things that they look at. For example, they would look at the benefits, okay, of the treatment. They would look at the safety of the treatments, okay, and then from time to time, of course, they would look at the cost. So the cost almost always, from what I have heard from the payer perspective, should come last. Okay, so the safety and the benefits should come first. But in reality, so when they after like the Ocrevus with the different dosage form, different strength, and the infusion either at the clinic versus at home, so you can see that there are some other factor in this one. Is like convenience, for example, something that you can administer, the treatment that you can administer at home, it's probably more convenient for you. But the convenience factor or the other stuff, when the payer consider and trying to, come up with a plan to coverage, quite likely that going to come, that is not quite their priority. So you can see that's why they decide to pay for certain thing or cover for certain dosage form, and don't really, or maybe ask you to pay or the patient to share more cost for, another form. And that's always the case. As I said. Yep.
And Chad, if I could add too,
Yep.
I think, the difference is Ocrevus is an infusion. So you have to have an infusion suite and an infusion nurse. And so I am on that infusion, and the drug cost is one thing, but the cost of doing the infusion is equally as much as the drug, if not more. Whereas Kesimpta, it's a self auto inject pen that you would just do yourself. So no nurse needed, no healthcare professional needed to administer. You do that at home in the comfort of your own home. But I think that's an important differentiation, because as somebody with MS and as somebody who treats MS patients, I agree with the neurologist's point of view that costs like DMT copay might not be the top concern. I mean, I've had patients with no insurance who we can get them the drug, but they can't afford necessarily the monitoring, the infusion costs. So for me, cost is so much more than what's the copay of your DMT. It's how much do you have to pay for the labs, and how frequently do you need those labs drawn? How often do you have to get an MRI to monitor either for efficacy or for safety? Because that has been a limiting factor in my patients' access to certain drugs. So cost of DMT, you have the direct drug cost, but you also have all these indirect costs of monitoring, copays for appointments. Sometimes you even have to do monthly labs for some of these drugs. So it really adds up.
Yep.
Let me weigh in a little bit on this Okravis infusion. I am also on the Okravis IV infusion as someone with primary progressive MS. That they have, Genentech has a copay assist program. So at the beginning of the year, a calendar year, you have a certain deductible amount as well as copay amount. And whatever out of pocket is that you're going to have to incur, that is subsidized by the Genentech copay assist program. So it is, if we look at what the net amount is, although when I look at my Okravis bill, it does explode out at me at the price point, which is unbelievable considering it only reduces my progression by 25% as somebody with primary progressive MS. But the actual out of pocket that the patient incurs, provided he gets some maybe information and assistance on completing the documentation for that, shouldn't be too bad. It should be relatively out of pocket affordable.
Unless you have a government health plan and you're not allowed to get copay assistance, right?
Was that right? I was not aware of that.
Yeah, that's only for private.
Oh, is that
in
right?
fact,
Oh, that's
yeah,
interesting. I didn't know that.
And I ended up looking into it because I had my 65th birthday right before my last infusion, and I knew that was rolling off. So
Yeah.
that's
Yeah, and there are foundations to assist, but that's the burden falls on the patient to apply to those foundations for financial assistance. But yes, the anti-kickback laws prevent Medicare, Medicaid, and military insurance.
Consider the kickback.
Yeah.
Yep.
But some
And those are very good
senators
points.
get 'em, you can't.
Yeah.
Those are very good point. And believe me, there's some other costs as well. Like for example, in the rural people who live in the rural area, when they need to have travel costs and time or it's just unbelievable. So it's not definitely it's not about the cost of the medication themselves, okay? But just like to make sure that we to be cautioned, this study really like to look at, I mean, was intended to look at only the DMT itself, okay? But I definitely agree with you all. There's some other things, allow that, okay? So let's move on. I really love this when people have questions, chime in, and and I have a lot of slides, but no worry. At the end, you will get to know what I did and get the result. Okay, so please feel free to ask the question. So anyway, from all those process, and then we ended up with the this is more like a our design, and we look at. We include 5 or 6 attributes here, which is the relapse, disability progression, severity of the adverse event, and route of administration, frequency administration, and the cost. Okay, so then we decide the questionnaire, which I don't want to spend
Yeah, just
time.
put a card.
Yep, I don't want to spend too much time, but this is how it looked like when the methodology that I used. So basically, we put together as a survey, and Holly was my angel at that time because she helped me, simplify the languages and all kind of stuff. I use some kind of technical jargons and that kind of stuff. Holly told me this doesn't work, and so on. She was my angel at that time. So she kind of helped me, kind of make it readable, and it makes sense or anything like that. So that is what we need to do. And at that time, this is unbelievable. This is the old number. At that time, the community is only like 26,000. And I believe, we have almost like much higher now, maybe over 6,000 or 7,000 now, if I am correct. So, but anyway, we sent out the survey to 12,000 people, and then we have some kind of methodology that we need to. Now here's the result. Okay, so we got responses back from 644. Oh no, in fact it's higher than that. So, but it got we got cannot remember. I should put it here. But anyway. So that was, and then we have the no response, we have some invalid response and usable. Anyway, the total usable response, what do I mean by usable? The total response that I included in my analysis in order to get the result, okay, is 508. Okay, so that are some people. So among those 508, the average age is about 52 and 53. The majority of them, almost 80%, female, and not a surprise, 96% was white patient, and would love to have more diverse, background, but that it's just the nature of the the community member at that time. So the majority are married, and then 35% have a 4-year college degree, or not 39 have higher than that, and then the rest would be kind of lower than had less than 4-year college degree. The employment status, the majority still not majority, in fact 36% employed, and then 37% disabled. And in terms of the health insurance, 61% have their private health insurance, and 30% is under the Medicare. So in terms of the MS experience, there's the average is about 13 to 14 years, and for the average number of relapse during the last 2 years, about 1 time. So this is the characteristic. And when we talk about, what type of the MS do they have at that time, of course, not a surprise, the majority have the relapsing and remitting. And we also ask them about the MS symptom. As you can tell, 22% of those 508 say that they are normal. They have 16% have mild disability, and moderate 10% moderate, and so on, as you can tell here. 1% are bedridden. And this is the DMT that they have experienced, okay? it's not only the DMT they were using at that time, but it's also the DMT that they have used and stopped using, or so whatever they have experienced. So at that for this group, among those 508, so 282 people have Copaxone, and so the majority of them have experience with Copaxone. So when you sum this number up, it's over 508 for sure, right? Because there's some people have experience on multiple drugs or multiple DMTs, and that's why when you sum it up, it's over 500. And here is the gist of the result. Okay, so you look at this. I don't know what color can you see. This is not my color that I made, but in red color. Okay, that is the manufacturer price, or what I put it here is how pharmaceutical industry value their products. Okay, in the blue bar here is how patient value it. So forget about the 6,000, 8,000, because this are all relative. Okay, it's not real number what I said. But if you can tell that patient, based on patient preference, they have different preferences across different type of the DMT, right? If you look at the blue bar here, okay. But on the other hand, from the manufacturer or the industry point of view, so the price are pretty much kind of close to each other. There's certain product that they price higher from another one. So you can see the inconsistency between how patient value DMT and the industry value the DMTs. Okay, so this is what we have. And again, the way that we calculate this, how patient value on this DMT, is based on the characteristic of the DMT only that we pick. Okay, so that's what we found. And we actually did more analysis within that, and then we kind of like to see, hey, what actually the factor, that associated to the how patient value the DMT. So we asked two questions. We actually analyzed, not asked, we analyzed our data into two questions. The first one is who is actually willing to pay or not versus not willing to pay, okay, for DMT. And the second question is who is willing to pay more. So we explore, the left-hand side, where what we call as the factors here, okay, on who like to pay, who not like to pay, or once they are willing to pay, who like to pay more. That is the question. Those are the questions. So it turned out that for the first question, we don't really find, what we call as an important or significant factors. Okay, only two of them, and which are the education background and the comorbidity. Comorbidity is basically other diseases that you have besides MS. Okay, well, not a surprise, right? So people who have either graduate or professional degree are more, willing to pay for the DMT as compared to people who have some or less of less than 2-year college degree. And people who have other diseases besides MS actually have a higher chance to pay or willing to pay for the DMT. And then the second question is, so who would be willing to pay higher for DMT? So we basically found male patients would be willing to pay higher, white patients, and this is not a good, because as you remember, our sample have a really not really good representation in terms of the race, right? So this is not a good real valid result, but it's statistically significant. We have people who have a higher educational background would be willing to pay more. That makes sense. People who are with private insurance, they would be willing to pay more, higher amount for the DMT. Patient with better health status, patient with lower number of years of MS, still willing to pay more, or patient with not don't have any mood change, would willing to pay more. What we cannot explain is the red color. and I still cannot find a good reason, but this is the result show. So the result show unemployed patient actually willing to pay higher for DMT. And I cannot find good reason to explain this result.
Chat, we have a couple of more questions if you want to take them now, or if you want to wrap up, and then I can read you the comments that we've gotten in.
I think I have only one more slide, so I'm gonna wrap it up.
Okay.
So if you don't mind, maybe less than 1 minute. So basically, in conclusion, patient view or value DMT, different DMTs differently, quite obvious. Okay, that is the conclusion statement for me. And we from this and this is all from your participant, from the community support from the community. So we were able to publish 2 articles of this project. And last, I really like to in fact I would exercise the question first before I talk about this 2 slides, Holly.
Okay, so we have a comment from David who said, I think this relates to the pie chart of people's disability levels,
Okay.
Who answered the survey, and it said that it appears that mobility is the only factor for assessing disability, but cognitive and emotional issues can also be disabling. I think it was the one with all the different pie pieces, probably from the patient disability or patient reported disease status. But yeah, I think that was the one there. So
This one.
yeah, so just
Yeah,
a
okay.
comment that this scale has a lot to do with your ability to walk, but that's not the only factor that affects whether you can function well in the world or not.
Completely agree. Completely agree. Yup. We did not capture that. So that is, yup.
And then the other comment is from Claire, and she says that date of diagnosis affects the choice of DMT available. So I suppose, Claire, if you'd like to elaborate on that, you can come off of mute, but maybe that means that when you're diagnosed and the
yes,
DMT is available. Yeah.
If you're diagnosed in the 1990s, you don't have a choice of some of the ones that are available now. So when you do a survey like that, which is the first choice or second choice, some of the choices weren't, depending on the date where the person was diagnosed, there were different choices available, I guess is what I'm saying.
You know what? That's I am actually got goosebumps right now from your comment or your question, because that's a real gist of the research that I like to do next. Because people with there's a technical term we call heterogeneity of preference. Okay, so but forget about that term. So what I'm trying to say is patients with different backgrounds, including years of experience, including their household income, including their races, anything like that, they may have different preference or different type of different values across these DMTs as well. You are definitely correct. I try to propose that, in fact, Holly, if you remember, to the society, but we did not really get support on that. But that's a real question. Thank you so much for listening, for bringing that point up. Impressive. Yep.
And then Yolanda has a question, or a suggestion actually. She said, for the unemployed patient results, were you able to ask in the survey if people were unemployed because of MS or for a non-MS reason? And that might explain this result. And again, Yolanda, if you would like to come off mute to provide any more details, you're welcome to.
Yes. Hi, chat. I think that finding is very interesting because it may drill all the way down to if there's a desire to get back to work. There may be some things that people are willing to sacrifice so that they can become able to work again. And that may have influenced how they answered that question. And so that's why I was curious if it was more of I'm kind of unemployed, not necessarily by choice, but it's because of, my illness at that time. And if there's a medication that is available that could potentially help improve and get me to the point where I can go back to work, then I'd be willing to pay for it because their intrinsic value would be much more because of how they could see it impacting a number of different aspects of their lives.
That's a real good explanation. You see that? That's why I keep telling my peer, my colleagues that you never start working with patients, okay? Because if you do, you will never be able to stop yourself. I wish that I met you, Yolanda, before I wrote that article. So basically, my explanation is just like I don't have good explanation, but that is it maybe. Yep, that's very good. Good. Thank you for that. Yep. That was a mystery for me, for like a couple of years. So
There you
any
go.
other points?
So the next study, you can involve patients in designing it too.
I think so. Yeah. You guess what? At that time, to be honest with you, this is my first project about MS, and I did not really know about patient engagement or that kind of stuff yet. And later on, though, after I got that project done, or maybe in the middle, I got the PCORI Engagement Award. Working with patients and their family members, and I enjoy that. I learn more and more and more. And you're right, Stephanie. Next time, you better put the patient on board from the get-go.
Oh, yeah, definitely. And then we have a question from Rich about chat. Do you classify moderate disability as in or using a wheelchair? How do you classify moderate disability, I guess, is the question.
Let me see if you mean this one. In fact, there was I'm trying. It has been a while, to be honest. So in fact, there is a scale that available out there to determine. Basically, it's just a question with this term, and then they have the description of this term. Like for example, this again, I cannot remember what exactly it is, but it would describe my disability. Like maybe you can still do your daily routine, but you cannot be active as much as you want or anything like that. It's a standardized scale, if you may. Yep. So that's what we use, and
Yeah,
not mine. It's from someone else. Yep.
I think I think just looking at the pie chart, it probably means not in a wheelchair. In fact, I'm looking it up now, and I'll read the definition. It says, I don't have any limitations in my walking ability. However, I do have significant problems due to MS that limit daily activities in other ways. So that's the definition of moderate disability.
Yep. I don't think, you will be right. Yep. You are right. Yep. Other questions?
And chat, we have about 7 minutes left. So I do want to make sure we get to our final question for you, which is, tell us a little bit about how you think iConquerMS is helping to shape MS research and the importance of it and why everyone here should participate. And then we'll close out the call with any remaining questions from people who dialed in.
Yep. Thank you for that question. I really love this question because I really like to say that, I was new. Can you imagine? I was new to the field at that time when this is my first project about MS. Okay. But, the support that you guys, gave to this project and was kind of overwhelming me at that time. And without your support, without your responses, I know that I need to kind of been through the process that iConquerMS has, to get approval and stuff. And I really appreciate those responses, and it's very critical for researchers, your responses, your feedback and stuff. And I was even more thrilled when I got the responses back. I told Corey at that time that the responses, you could tell as a researcher, the responses that I got is the cleanest responses that I almost ever have at that time. So what does that mean? That means patients in the community, when they respond to the survey, they carefully responded. So there's no inconsistency, that's what I meant by unclean response. Okay. I really like to say that in front of the community. I'm so thankful to be able to, to get the support from the community. Yep. And if there's no other question, I have 2 more slides to,
Can I just
to
ask
go.
can I just ask one quick question, chat?
Sure. Yep.
And that would be, what did the MS Society think of the research results, because they funded the study? And then also, how do you think your results will benefit people with MS?
Well, good question. The thing is here, the key thing of this one is how patient value the products. Okay, so when it is published out there, so I really hope that the providers or the payers, okay, will actually have an opportunity to learn about the results. So then it will, because if you remember, I mentioned a few minutes ago that the conversation about coverage is almost always between the payer and the providers, and the patient voice never been included. And then quite often those 2 parties would say that, well, we don't have any really good information about how patient value. We have individual communication with each patient, but not an overview. But when they decide the policy, the reimbursement policy, so now this piece of research will actually kind of provide them the patient perspective when they're going to come up with the reimbursement policy, and if they like to include patient preferences into their decision making, that's going to have an impact on eventually subsequently to the patients. Do I answer the question?
Yes.
Sorry.
And did you get any feedback from the MS Society who funded the study?
I actually not directly.
Okay.
Yep, not directly. Yep.
But they do have, and other groups do have departments that are working on reimbursement issues. So, hopefully they have seen the results and are using that in their conversations with payers.
Oh, that part I forgot, Hori. I'm sorry. I actually met with they have some a function, and actually share the result with them as well. They asked for the result, and but I don't know what happened after that. Yep.
Okay. Oh, and we do have one more question, and this is from Linda. She says, so patients might be asked to pay more. So from your research that shows that certain attributes are desired by people with MS, could a payer say, oh, well, in that case, we can put more of the burden on people with MS because we're offering them treatments that are meeting their needs? Do you think your results could be taken that way?
I definitely not. In fact, in the article that I wrote, I made it very clearly. Okay, the willingness to pay, this is based on what is an economic term. And never, I stated, explicitly that never ever think that this is, use this number to price the products, because they're not capable to do that. On the other hand, this willingness to pay can be used to reflect how patient value the product. That's it. So I make sure that I made that statement, explicitly. But if somebody come with some kind of a specific agenda and would like to take it that way, I would really disagree with that. Completely disagree with that.
So it's more about just communicating what patients prefer, what people with MS prefer.
Correct. And if they take the result that way, they are definitely wrong.
Hope I interpreted your question right, Linda, and if you had anything to add to that, we do have 1 minute left. You could come off mute.
No, that's fine.
Thanks for your question.
Thank you for that question. Yep.
Okay, so if there's, I think you have just a question about or update on the future programs.
Yep. So here's the plan. As I said, this is not only chat with chat because I am the speaker today. I'm actually more like a guinea pig. That's for me. That's my term. So it's turned out that we have the next step committee that we're going to work together and then decide. But the preliminary plan is for the future program. We plan to do it like this every other month, not with me anymore, maybe time in the far future, but we're going to have different speakers or different researchers who work with the community. This is more like a give back or build the relationship between the researcher and the community. That is our mission. And we'll be in touch soon. Okay, so with that. And then the last one, I really like to my special thank not only for the MS Society that funded this project, and again to iConquerMS and our so-called Next Step Committee. I did not put the names here because to be honest, again, I forgot to ask for their permission if I actually can say their names here. So I'm just gonna go by only Next Step Committee. And that's just it for me.